Hello and welcome. Thank you for tuning in. I'm Dr. Rob Cotes, an associate professor at Emory University School of Medicine, and today we're going to talk about guidance for managing the unexpectedly high or low clozapine level. So I am the director of the Clinical and Research Program for Psychosis at Grady Health System. And in that program, we have an early psychosis clinic, and we also have a clozapine program where we manage over 100 individuals who take clozapine. I also serve as physician expert for SMI Advisor, and in the consultation service at SMI Advisor, we get a lot of questions about levels that are too high or levels that are too low. I've probably had in the last year or two 25 consults on levels that are too high or levels that are too low, and we get a lot of questions about how to manage these. So this is a really clinically relevant topic, and we're going to talk a little bit about some of the background of clozapine and its pharmacokinetics and how to interpret clozapine levels. And here are my disclosures, which are available to you. The learning objectives for today's talk are threefold. So after you leave here, you should be able to understand basic principles of TDM for clozapine, including when to get a level. You'll be able to critically assess the possible causes of elevated and low levels of clozapine. And then we'll also put some parameters around what does actually elevated levels mean, what do low levels mean. We'll talk a little bit about the management strategies for levels that are too high or levels that are too low, and also when to consider getting a repeat level. So everyone here is probably aware of many of the basic principles of TDM for clozapine, but I want to review it just a little bit because they are the foundation in managing the unexpectedly high or unexpectedly low level. And just as a disclaimer, this talk is going to discuss sort of the unexpectedly high or unexpectedly low level after someone has been taking clozapine and you have had a series of levels. This doesn't address, the situations in which you have someone who has never gotten a level that's detectable. That's sort of a different issue. So basics on clozapine. From the APA guideline for the treatment of patients with schizophrenia, clozapine shows up in 3 places. 2 of them are FDA approved, and then the third one is for the risk of aggressive behavior, and that remains substantial despite other treatments. So bullet number 1 is for treatment-resistant schizophrenia, and then the second is for the risk of suicide remaining high despite other treatments. Most psychiatrists and other prescribers, if they do use clozapine, it's for the first indication. It seems to me like we really don't use enough clozapine at all for people who have had a serious suicide attempt or when suicidality is part of the picture. So I really would encourage people to consider using clozapine for these folks. We're going to run through real quick a couple of concepts about clozapine levels, when you would want to get them, when you would want to draw one from a timing standpoint, how would you interpret the level. We're going to talk about the therapeutic threshold, the point of futility, and then a little bit about the coefficient of variation. I think that there has been a bit of a paradigm shift in the use of antipsychotic plasma levels over the last 5 to 10 years in the US. When I was a resident, we really didn't talk a lot about TDM for antipsychotics. And now I think we've really come to understand just how valuable they are. I especially appreciate levels since our institution has implemented the real-time immunoassay test. Later in this talk, I'll review some case studies that will demonstrate just how real-time clozapine levels can be helpful. So the other thing I wanted to mention that is if you are sitting in this presentation and you don't use clozapine levels, that's okay too. You're not alone. In a survey that we recently did, only 47% of psychiatrists in a national sample actually used clozapine levels to guide dosing. And although the study was published in 2022, we did that survey 3 years or so before that. So I wonder if there's been a little bit of a change. There's been a lot of really good educational efforts out there with the publication of the Clozapine Handbook, SMI Advisor, and I think just additional information and awareness around clozapine levels. So the ASCP and TDM task force of the AGMP has divided the use for TDM of different antipsychotics into different categories based on the available evidence. And it doesn't come as a surprise to us that that clozapine would, of course, be strongly recommended. Clozapine has somewhat of a narrow therapeutic index, and there's actually been a lot of data for the use of clozapine and TDM. Also in the strongly recommended category are fluphenazine, haloperidol, olanzapine, and perfenazine. In this table, I didn't describe all of the antipsychotics, just the ones that are available in the US, and tried to keep the figure relatively simple. Okay, so moving on, why use TDM? And I will put forward 4 different reasons. The first reason is medication adherence. Many people don't take antipsychotic medications consistently, and there have been economic analyses that suggest that improving adherence can actually save the healthcare system $1,500 or more per year per patient. We also have to understand that there are biological variations in the population, and this governs different aspects of drug metabolism. Not everybody is the same. Some people don't respond as we would expect to antipsychotic medications and clozapine. So the stakes are high. People who take clozapine often have treatment-resistant schizophrenia, and when you're at that point, it's not expected that any other medication would be likely to work. So we have to figure out, we have to have a tool to help us figure out why a treatment is not working if we have unanticipated side effects, and then what to do with it. So for me, TDM actually offers prescribers more comfort when using clozapine. So if you're new to using clozapine, you can actually use a level to help you guide decision making. So I think that using levels actually makes things less complicated rather than more complicated. Now, going back to the ASCP AGMP guideline, there's a number of places where TDM can be useful. I'm just going to highlight a couple of them. Uncertain adherence, lack of response within established dose ranges, symptom recurrence during maintenance treatment, which is sometimes called breakthrough on antipsychotics maintenance therapy, or BAM, with long-acting injectables, adverse drug reactions, and then a whole host of other instances where TDM can be helpful. If you can get the levels back within hours or at most the next day, the clinical utility of these tests is vastly improved. When we talk about clozapine levels, it's important to identify the right types of patients to be on clozapine. We all know that clozapine is highly underutilized in the United States. It's underutilized many places around the world. And the only way that we're going to improve this is by starting new patients on clozapine. Now, I do a combination of first episode work and clozapine work. And as a psychiatrist on a first episode team, we have the opportunity to really reduce the number of antipsychotic trials that people have and keep track of it a little better, and actually introduce clozapine appropriately and at an early stage. And based on the data, including this Yoshimura study, I think this is very compelling. The earlier you introduce clozapine, the better people end up doing. There's a notion that clozapine is a last resort for some people, but clearly after only 2 antipsychotic medications, and some data would even suggest 1, we really need to think about clozapine. So again, the shorter the delay to clozapine initiation, the better people end up doing. Now, that's not to say that if you introduce clozapine later on, it's futile. It can still be useful, but early introduction is really, really important. Okay, everyone is also aware of clozapine's biotransformation to norclozapine by various enzymes in the CYP system, including CYP1A2, which does the majority of the heavy lifting. Inducers are going to decrease the level, and we're showing a couple of those here, like the aerohydrocarbons and omeprazole. Inhibitors are going to increase the level, like fluvoxamine and ciprofloxacin, which actually inhibits all 5 of the CYP isoenzymes involved in clozapine's biotransformation. Other things like oral contraceptives And caffeine, which is a substrate, can also affect levels. Clozapine levels are actually measured by two different ways: LC-MS-MS, that's liquid chromatography with mass spectrometry, and then the real-time immunoassay produced by Saladex. The immunoassay has several advantages. In our institution, we use the immunoassay, and our patients benefit from the rapid turnaround of results. Unfortunately, not all patients have access to the rapid results. We also have patients who come from all around the state who use blood levels that are reported by LCMS, and we have to try to make decisions, even though sometimes a fairly long time has passed when the blood levels are drawn and when we actually see the patients. So this is not an ideal situation. In addition to the faster turnaround time for the immunoassay, the test can be run in-house, where typically LCMS is a send-out test, and that adds to the time in getting the results back. The immunoassay is also FDA cleared, and there are several advantages with being FDA cleared. The LCMS is a lab-developed test, meaning each laboratory has its own method, and you can't actually compare results from one LCMS test to another from a different lab. And then also, finally, the slide shows that the immunoassay is a cost-effective in both time to the result and the actual cost of the test. So a couple of notes about some of the advantages from a workflow standpoint we've seen with the Saladex assay. The core advantage is having this is basically you get the results back on the same day rather than having to wait 5 to 7 days. So our current workflow kind of goes like this, is the way that's described on the slide. I run a clozapine clinic, and many clozapine clinics take place in the afternoons. Mine is not an exception. So what we do is we have patients come in the morning, if they're able to do it, and then get their blood. We then have somebody maybe go to a group, and then they come back and see us in the afternoon. And then the big advantage here is we can actually discuss that level that was obtained earlier in the morning, right in front of the patient. It gives us much more confidence to make a dose adjustment if necessary. And it comes up a lot, especially if somebody has a low level, and we provide instructions about how to do a clozapine retitration, which can be a tricky issue. Now, we're not able to do this for everybody. Some individuals are working or in school, and we just get the level whenever we can. But still, having a level come back the same day makes a much more actionable, you can make a decision based on that. So ideally, this is how we like to structure it. Now, let me show you a little bit of a contrast here. This is the scenario that we see when people get their labs elsewhere. We typically like to have the patient get the blood work maybe 7 days before they see us, and then meet with them, as you can see here, on day 0. That way, when the level returns, we can talk about a relatively recent level with the patient right in front of us. But a lot can happen over those couple days, and it's impossible to respond in real time to those issues. So that's just a little bit about fitting clozapine levels into your workflow, whichever method you're using. Let's go back to the basics. Okay, so the ASCP AGMP guidelines recommend a reference range of between 350 to 600 nanograms per mil. But if you have a patient who's got persistent positive symptoms despite a level of 350, and they're tolerating clozapine adequately, what else are you going to do but increase the dose to get you to a higher level? We'll talk a little bit about the data here. The risk of ADRs does increase likely above 1,000 nanograms per mil. Certain side effects are also probably more dose dependent than others. For those of you who aren't in the United States, there's a conversion formula on the slide that takes you from nanograms per milliliters to nanomoles per liter, in which you basically multiply it by 3 times. It's important to think about, when do you actually obtain the levels? We really try to get clozapine levels as a trough if we can. So once someone has reached steady state concentration, we get the level in the morning plus minus 2 hours. So this is about 12 hours after the bedtime dose. This is the convention. In our clozapine program, we really have everybody on bedtime dosing with very few exceptions. And we have seen instances where we get elevated levels back, where someone might have taken their AM dosing. We get a high level, there's a panic alert. We talk to the patient, they're doing just fine, and the reason is they took their AM dose. So when you get clozapine levels, whatever method you use, please advise people to hold the AM dose if they're on divided dosing. Another key concept to talk about is the coefficient of variance. And I have a lot of patients and families who tell me, oh, my clozapine level was a little bit different than it was the last time. Like it was 350 and now it's gone to 340 or 330. What are we going to do? What's happening? What's different? Just keep in mind that there is an expected 30% fluctuation with clozapine levels. I made a graph here so you can see a little bit about this hypothetical variation. The first three levels, are kind of around, in the 350 average range. Now, if you look at the bounds of the coefficient of variance that I made, on the high side, that would be at the 450, on the low side, maybe about 245. And what we see is that this hypothetical patient runs kind of within that. And then there is an elevated level here towards the end. I would typically think about fluctuations greater than 50%, especially like if it's less than 50% as a non-adherence issue. And to give you a little bit more clues, what we'll do is we'll talk about the CD and the MR and how these are affected by adherence a little bit later in the presentation. Okay, the first is the concentration dose ratio, thinking about clozapine levels. And what's really important to take away from this slide is that a female non-smoking patient needs about half the dose of clozapine to get to a level of 350, in comparison to a male smoker. So again, a female non-smoker needs half the dose to get to a level of 350 than a male non-smoker. This is based on data from one of the normograms out there, and this is the one that we use to help fuel the clozapine dose planner for SMI Advisor. And I think what this really speaks to is personalized dosing for clozapine, and again, just how important the levels are in being helpful for your patients. I now want to show you the clozapine dose planner. And from the clozapine dose planner, you have two options. You can predict the clozapine level based on the dose, and you can also predict the clozapine dose that would be needed from a certain level. And I like to use this second bullet when I'm talking to my patients. So if I'm starting a new patient on clozapine, I'll pull this clozapine dose planner up and say, okay, we're choose number 2. As a ballpark, we want to get you to 350 nanograms per mil. What is the dose that's going to get us there? And then what you do is you plug your information into the dose planner and see what would be the recommended dose based on a few variables. It's not comprehensive. It's kind of rough. It's a ballpark. This includes smoking status, male, female, weight, age. We have the clozapine level on the slider set to 350. And you can see that for this patient, the recommended dose would be around 517 milligrams. I think this is a great tool if you work with trainees, so they can see how these major variables would affect the predicted clozapine dose. Now, the model that I showed you is not a comprehensive one. There's a new model that was published this year by some authors, including Robert Flanagan, who was part of the normogram that we just showed in the earlier slide that also includes ethnicity data. And we're increasingly understanding the role of DNA ancestry in developing individualized clozapine dosing. So they found in this new normogram, in the new study, that individuals of Afro-Caribbean DNA ancestry had 12% higher clozapine doses to get to similar levels. People of Asian ancestry, 19% lower levels to get to the same dose. So again, speaking to the personalized dosing that's really helpful for clozapine, and you really don't know any of this information if you don't get a level. Now on to the metabolic ratio. The metabolic ratio um, gives you some clues about what's happening kinetically with the patient. And I think there's some debate among clozapine experts among about is the metabolic ratio valuable or not. But I like to use it if I have it available. And what you do is you take the clozapine divided by the norclozapine level. It works because the norclozapine half-life is longer, as you can see in the slide, 19.2 hours versus about 10.5 hours for clozapine. It helps you to understand if there's an inhibitor or an inducer on board, and it remains relatively unchanged during periods of non-adherence unless the clozapine level is taken just prior. And I think that, again, the metabolic ratio, if you have the information, it's sometimes helpful to get it. But in our setting, having a rapid clozapine level is more important than having to wait 5 to 7 days to get a clozapine and norclozapine level back in the vast majority of circumstances. Okay, this is a little bit more about interpreting the norclozapine level. And you can see on the lower side, like if the metabolic ratio is less than 1, it's usually because there's the presence of an inducer like smoking, carbamazepine, or omeprazole, or someone is a CYP1A2 ultra-rapid metabolizer, which is relatively rare, maybe about less than 3% of the population. Now, on the other side, on the high side, if you have a very high metabolic ratio, consider the presence of an inhibitor or an infection. I like to tell our trainees to keep track of this in a systematic way. So every time you get a clozapine level back, you want to report it in the chart and report it on the note for your patient. Sometimes your EMR might not have them, particularly if it's a send-out test. So the first thing you do is during a period of good adherence, you want to establish a baseline, which is essential for interpreting clozapine levels. With the level, with the clozapine level, the norclozapine level, the clozapine dose, CD metabolic ratio, and you can sometimes have these things pre-populated if you have access to this in your EMR, but I haven't been able to really do that. Part of the issue too is the EMR might not have all the information about the clozapine levels that you need, which I think actually is another advantage of the immunoassay. So that's something that kind of pops up in our EMR for us, rather than having to look in a different system. Okay, when you think about unexpectedly high or unexpectedly low levels, you have to think about how your levels come back and what is your process for that. So there are many similar principles that actually you can transfer over from clozapine hematologic monitoring. For example, if you have somebody who gets an ANC back and their ANC is 0, what's your process for that? How quickly do you contact someone and tell them they need to go to the emergency room immediately? Who reviews them? What is the on-call plan? Many clozapine programs have some sort of infrastructure in place to manage this, and you can leverage that infrastructure as well to think through high and low levels. In our setting, in our own lab, we use the immunoassay pretty much exclusively, but we have about 20% of our patients who come from other places throughout the state who get their labs elsewhere, getting the LCMS. So you have to figure out how your system is going to incorporate data coming from different places. Are things coming from your own EMR? Are things coming to a fax machine? Are things coming to a different system? What are the laboratory alerts? How quickly do you get the results? What's your after hours plan? And in our setting, if somebody has an ANC of 0, the attending gets a call, usually during the day. But if this happens in the middle of the night, there's sort of a different plan in place. And the same thing kind of has to be thought through with the levels. Like, what's the panic result for a high level, for example? Okay. Now we're going to go over some specific considerations for levels that are too low. I put the magnifying glass on here because there are a bunch of young kids, a bunch of my young kids in the house, and we have magnifying glasses everywhere. So this is on my mind. But seriously, you have to do some detective work around when you obtain the levels that are too low and when you obtain the, and you know, kind of what do you do with the levels that are too high or too low? So the first question is, what are levels that are too low? How low is too low? And it depends actually on the limit of detection for the various lab you're working with. With the LCMS, the limit of detection ranges, and it can be between 10 and 100. With immunoassay, at least at our lab, the limit of detection is 68. So the other considerations, you want to think about the baseline clozapine level during periods of good adherence. Are you within 30% of what's expected? Or is it within 50% of what's expected? Or is it completely undetectable? To do anything with the level, you really have to have more than one level. You have to know what the baseline level is. A single level in the absence of a baseline means nothing. Now I'll present some explanations for unexpectedly low levels. This is why the fundamentals of clozapine and its metabolism are very important. So let's go ahead and walk through them. The first question is, are we actually looking at a trough or not? Were the baseline levels that your sort of knowledge is built around, were those true troughs? I have patients who are on bedtime dosing, but sometimes they don't come into the clinic until 3 p.m. and they get their lab at 3 p.m. So it's not exactly a trough. All right, next. When we think about the pharmacokinetic changes, is the patient smoking? Are there inducers on board? Are there moderate inducers on board? Is the patient on valproate, which probably functions different if somebody's a smoker versus a non-smoker? If somebody's a smoker, it may act more like an inducer. If they're a non-smoker, it might act more like a mild inhibitor. The other thing to think about is adherence. And keep in mind, adherence is a dynamic process. So it's not whether people are just adherence, yes or no, in a categorical way. There's partial adherence. Adherence changes over time in a dynamic fashion. I work with a lot of first episode patients, and I expect adherence to change over time. So don't be surprised when you get low levels, unexpectedly low levels. Like we talked about earlier in the presentation, always low levels is a different category, like always undetectable. We get a lot of consults about this in SMI Advisor too. Like you have a patient who comes in, they're on 300 milligrams of clozapine. They have always had an undetectable level. That's, more likely a non-adherence issue than it is to be an ultra-rapid metabolizer issue or even an absorption issue. So it's important to kind of make this distinction between unexpectedly low levels when you have a baseline and then a decrease versus someone who's always been always low. Okay, now we'll talk a little bit about smoking. It takes 7 cigarettes to fully induce CYP1A2. So it doesn't matter if you smoke 1 pack a day or 2 packs a day, CYP1A2 is going to be maximally induced. When people start cutting back on their smoking, going from a pack a day to maybe 4 cigarettes to 0 cigarettes, this is where you're going to expect some changes. Now, everyone is probably aware of this, but some people might not be. It's the nicotine, it's not the nicotine patch or the nicotine gum that causes the changes. It's the aryl hydrocarbons that are produced from cigarette smoke that bind to the aromatic hydrocarbon receptor. And what happens is you get increased expression of mRNA, and this actually ramps up CYP1A2 activity. This happens over a couple days. It also probably happens for smoking cannabis, although it's been studied less. So if people are smoking a lot of cannabis in a joint form, there are probably some aryl hydrocarbons being produced. All right. I also like to tell people a few things when they get started on clozapine. One of the most important one is be careful about ciprofloxacin. Don't let anyone prescribe ciprofloxacin without you knowing it. So also, if you get infected, if you have a patient that gets infected with COVID, you want them to let you know as soon as possible. If you have changes in someone's smoking status, they need to let you know. There's a lot of education that goes into it, including the 5-box warnings. But I tell people, you know, let me know if these things are going on. Let's develop a way to communicate these changes if something happens in between the appointments. If you have someone who abruptly stops smoking, consider a dose reduction of 30%. On the other hand, if you have someone who goes from a smoking facility to a non-smoking facility where they can, where they can smoke, we use the immunoassay to get clozapine levels to help understand that transition. And a lot of times I probably will not actually increase the clozapine dose empirically in that situation, but it's a question that comes up. And sometimes if people are still, symptomatic, maybe they were discharged from the hospital a little too early and they come out of the hospital and they start smoking a pack or two, I might actually increase the dose at that time, guided by levels. And when you have the immunoassay, the levels come back much more quickly and it can help you figure out these transitions between inpatient to outpatient settings more easily. Okay, so for partial non-adherence, there's usually 3 conditions that are true. The metabolic ratio will be similar. The concentration dose ratio will be decreased. And then the level itself will be outside of the 30% coefficient of variance. So let's say we had a resident who drew up the table like I recommended earlier, and it looks something like this. Now, the first 3 dates, dates 1, 2, and 3. If you look at this, it kind of looks like the patient has been taking the clozapine pretty consistently. We have a 367, a 332, a 350. And then on day 4, you see a pretty significant drop to 150. Now let's look at how the norclozapine level looks here. The clozapine dose has remained the same, 325. The concentration dose ratio is significantly less. The metabolic ratio is about the same. So it looks like that's a partial non-adherence situation without any of the other considerations. Okay. Now, another question is, how would we calculate the level that is actually outside of 30% outside of the coefficient of variance? And you can do this by getting the mean of the first 3 dates, which is 350. Then I would take the percentage change for day 4. You can do that by taking the level for day 4 and subtracting it from the mean level, then dividing the mean level times 100. And mathematically, you can see that there is a 57% reduction. Okay, so I would say that this patient has been partially non-adherent. So you really don't have to go through all this. I think you could pretty much just look at this, ballpark it, and say, okay, pretty significant level reduction, and you can see that the 3 conditions are approximately true. So if you have somebody who has a level that's less than, with a level that's 50% less than expected, or if it's undetectable, the first thing to do is to call the patient. I like to do this as soon as the lab comes back. And sometimes if I'm really worried about someone, I'll call them, pretty late. And it just depends the clinical situation, how much I'm worried about them. If you have that level in front of you from earlier in the day, you can really obviate a lot of this. So there's a couple of things that you can ask patients about. You ask them about the availability or access to the clozapine. Like, was there some issue at the pharmacy? You can ask about recent adherence over the last 5 days. If you're getting the LCMS, you want to ask them about adherence prior to the time the level was drawn, and sometimes there can be a delay. You want to ask questions, detailed questions, if there's been any medication changes. Scour the electronic medical record, including other medical records, to make sure that people haven't been started on some kind of medication that you're not aware of. Maybe from primary care or an emergency room visit where somebody might have gotten an antibiotic. You also want to do routine things like ask about over-the-counter supplements, herbal supplements, prescribed medications, changes in smoking, especially changes in mental health symptoms if the level is low, and sometimes getting the family involved can be helpful. With low levels, I also ask about anticholinergic withdrawal symptoms, which can sometimes include catatonia. And another thing you can do just to kind of double check is check the PSF on clozapine REMS to make sure that the patient has actually an active PSF to rule out availability issues. Okay, I mentioned anticholinergic withdrawal a moment ago. If somebody has low levels, we all know that clozapine is highly anticholinergic. If somebody stops clozapine abruptly, some people are very sensitive to this. And one study actually looked at abrupt discontinuation of clozapine 200 milligrams in 28 patients. And you can see what happened to them here. 12 had mild withdrawal, which included agitation, headache, nausea. 4 had a moderate withdrawal. And then 1 had a severe withdrawal, which actually included a rapid relapse of psychosis. In my experience, some people are very vulnerable to this, and other people demonstrate no anticholinergic withdrawal symptoms. This can happen with doses as low as 50 milligrams. A key thing to keep in mind is that for some people, you may need to replenish the anticholinergic load with benztropine if clozapine is stopped abruptly, or if they need if clozapine stopped abruptly, like think about anticholinergic use here. As a general rule of thumb, 50 milligrams of clozapine is equal to 1 milligram of benztropine in a non-smoker, and 100 milligrams of clozapine is equal to 1 milligram in a smoker. So I used to work in an inpatient setting, and I would see some, pretty acutely ill folks who came in. Some people would come in with clozapine and a question of myocarditis, so they might have an elevated CRP and troponin. In those situations, we need to stop clozapine abruptly, and sometimes we would use benztropine in those situations. And just to remember that although sort of substitute antipsychotics like olanzapine are really highly anticholinergic, they're not as anticholinergic as clozapine. So sometimes you need to add additional anticholinergics during these rare situations. Okay, so to further illustrate this point, let's talk about some examples. Example number 1, we have a 44-year-old patient who comes in on clozapine who reports that they're still having symptoms. On the day they come in, the level is taken and it's reported back to us. The clozapine level is undetectable. With the same day drug level information in front of them, the prescriber asks them about medication adherence, and they tell us that they have missed the last 4 days of medication. So rather than, I think, without a level coming back on the same day, there might have been a consideration to reflexively increase the dose to 350. But what we did was we had to retitrate clozapine over the next 3 days and then sort of assess how they did next week. So retitrations come up a lot. There's not a lot of guidance. I just wanted to show everyone here some of the new language in the package insert about retitration that was updated in 2023. The pre-2023 language is on the left side, and then the updated language is on the right side. And then the red, I've highlighted kind of what the changes are. So now if the US package insert says, if 1 day's dosing has been missed, resume treatment at 40 to 50% of the established dose. If 2 days have been missed, resume dosing at approximately 25% of the established dose. I think this is more helpful than the previous guidance, but still there's some questions that remain, like how quickly do you do the rest of this? So there are some real risks in balancing the retitration appropriately. There's dangers to going too fast. There's dangers to going too slow. For example, if you go too slow, you worry about symptom exacerbation. Some people are very vulnerable to this. Just a few days without clozapine results in additional symptoms of psychosis, could result in prolonged suffering and also medication withdrawal and anticholinergic withdrawal. Too fast, you worry about tolerability issues. You worry about hypotension, potentially seizures. And also another key consideration is the practicality of the retitration that you suggest. Sometimes simple is better than really complex. You have to think through what milligram, what tablets do people have available? What can you actually do? Another question is, do you have to add back an anticholinergic medication or add even a second antipsychotic medication? And if people have been, off of clozapine for 2 weeks, it does make sense to go, you really think about a slower titration, starting at 12.5, 25, and then getting people up. It's very tricky. So a couple of things I like to ask patients who have missed a couple of doses of clozapine. And really, believe it or not, this happens to everybody. And someone's previous experience can be quite informative about how sensitive they are to the retitration process. So I'll sit someone down and say, look, no judgment here, but have you ever missed a couple of days of clozapine in the past? And how was it for you? How did you restart it? How did you do? And sometimes that information can help guide you. Then you have to think about the logistics. What milligram tablet does someone have? Do you need to write a new prescription for a different milligram tablet? So if somebody just has like 200 milligram tablets, for example, you can't start back at 12.5. You have to think through some of those practicalities. So now I want to go back to the case one where we had the patient who had non-adherence, and we did a retitration, and this is how we did the retitration. We did it over 4 days, 25 milligrams, then we did 100 milligrams, 200 milligrams, and then 300 milligrams. So we did that over a 4-day period. And again, without the level, we wouldn't have been clued out that there was maybe a non-adherence picture. Maybe we would have got it, maybe we wouldn't have gotten it. Okay, here's another situation. We have a 33-year-old female patient with a history of schizophrenia on clozapine, 275 milligrams, doing well on monthly monitoring. The level usually had returned in the 500s. There were no prior instances of lower levels. We get the level back on the same day. It was less than 68. So we gave her a call, and we were wondering actually why the level was less than 68. And she told us that she was pregnant and she had stopped clozapine 2 weeks ago. So this, I think with that level that was less than 68, that actually triggered us to reach out to her and, have a discussion about clozapine and pregnancy. And now sort of if you fast forward, she's had a healthy baby. Baby girl, she's doing great. She did really well with the pregnancy. She got restarted on clozapine from a mental health standpoint, no exacerbation of symptoms, did really well. Good outcome. Okay, now on to the other side. What about levels that are too high? The first question is, what is a level that's too high? And when considering efficacy of clozapine, there's some variation in terms of what number you would try to get somebody to. Particularly if there's persistent positive symptoms, maybe you want to get the level to 350 nanograms per mil. And there was a recent meta-analysis from Corinne Northwood and Dan Siskind that looked at the optimal benefit of clozapine, concluding an optimal benefit of 372. So 350, 372, whatever your number is, doesn't matter all that much. Interestingly, the interquartile range was from 223 to 558. Some people needed lower levels, some people needed higher levels, and they could conclude that 250 to 550 could be recommended. But sometimes higher levels may be beneficial. And this is a study by Yada and colleagues that looked at higher levels, so 600 to 1,000 nanograms per mil. And what they found was individuals had an improved BPRS score of 2% for every 100 nanograms per mil of an increase. So if someone was doing fine without symptoms, there's no need to increase. But there are sometimes people who have persistent symptoms when you get over that 350 range, over that 600 range. And what are you going to do? But I think increasing the clozapine dose to get to a higher level really makes a lot of sense here. Now there's a concept that I want to talk about called the point of futility that Dr. Meyer talks about in the clozapine handbook. This is where the upper limit of plasma levels is described. The point of futility is thought to be around 1,000 for clozapine, and at that point, less than 5% of individuals would be expected to respond to higher levels. And in my clozapine practice, there are very, very few people that are walking around with a level of greater than 1,000. And we have some people maybe at 1,200 who, if we decrease the dose a little bit, will have a symptom exacerbation. We just can't get them any lower. But really, it's a very, very rare thing. We had a patient the other day who came in who had a level greater than 1,500. I don't think the level had ever been checked. So very, very gradually, we were able to reduce the level without a significant symptom exacerbation to get them to a slightly lower level than 1,000. And the patient tolerated it very well. There was no symptom exacerbation. And I think we all felt more comfortable with that. Okay. If you have someone with a high level, this is something that you can consider. This is a little bit about the thought process. You know, first of all, what's your threshold to call the patient? How high is too high for you? If you have somebody who's at a 500 level and then they have a 1,000 level, that's somebody you may consider giving a call to. Then go through the rest of the exercise. Is it a true trough? Were the baselines troughs? Is it a lab error? Did they stop smoking? Are there strong inhibitors on board? Are there moderate inhibitors on board? How are they taking the medication? Go through how many pills and at what time. Maybe they took more than what was expected. Run through signs and symptoms of infection systematically. But most importantly, communicate with the patient and their support system, particularly if you're worried. Here are some clinical interview tips when you're on the phone talking to that patient. Part of it depends on when you get the level back. And I've had situations where we've gotten a level back 7 days after it was drawn and the level was 1,500. We talked to the patient and it happened a while back. And we're trying to figure out what's happened since then. And the level may still be high, it may not be high. It's hard to know. It's important to get a detailed medication history as well. You want to clarify the dosing around the time of the level and since the level was taken. And that's, I think, complicated if you have to wait longer to get the result back. When the level's too high, you also want to ask about side effects. You want to ask about particularly some of the dose-dependent side effects with clozapine, like tachycardia, sedation, constipation. You want to ask about things like seizure, fall, confusion, slurred speech. You want to also ask about signs and symptoms of infection. And then if there's really no apparent cause, maybe get another level. Want to now walk through a couple cases which highlight some of these points. So in case example number 1, we have a 39-year-old man with schizophrenia who's on clozapine 750, aripiprazole 30, haloperidol 7.5, bupropion 150, and escitalopram 25. They have persistent positive symptoms. A level has never been drawn, it looks like. The level is greater than 1,500. They've been tolerating clozapine well. They've had no seizures. They're not on an AED or anti-epileptic medication. And then let's sort of fast forward again 6 months here. We've been able to reduce the clozapine dose. The levels are still elevated. And, we're kind of thinking about an AED. Case example number 2, 55-year-old man with schizoaffective disorder. He's on clozapine 450, lithium 900, and Depakote one 1500 at bedtime. Historically, as you can see from the graph here, the levels have been running in the 700 range. And we last saw him in the clinic about 25 days ago, where he was at his baseline. So in the emergency room, there was a level that was drawn, and the level was really elevated. It was 1300, and he had had a fall, and he had altered mental status. And in our emergency room, we used a rapid immunoassay, and the result came back right away. It was obvious that the level was very high. They did a COVID test, and he was COVID positive. So we see this with other infections as well, not just COVID, including other respiratory infections, viral infections, really anything that can cause a fever. So our patient had, an increased level. There was an infection, and we immediately decreased the dose to 1/3 of the original dose. In our and really levels helped us to get back this patient to the usual dose over a couple of days. We have told everyone in our emergency room to use the Clozapine same-day immunoassay once someone presents who's on Clozapine. That gives us so much information very quickly. Okay, case example number 3. This is a 22-year-old male who's been doing well on 800 milligrams of Clozapine, currently in school. They met with us to get the medication and pick up some and get the labs. Clozapine levels, been fluctuating, but kind of around the 700 range. We got a level, and on that day, the level was 1200. So we said, oh, that's a little unusual. What happened? So we did a little digging in the chart, and we learned that this patient actually had a seizure at an outside hospital because he had abruptly stopped smoking. So he went from 1 pack a day to none, had a seizure, but actually we didn't talk about this during the appointment. He didn't mention it. So the level kind of clued us in on that same day to look at the EMR in a more detailed way, finding that there was an external record where the patient came in and had a seizure. We called him back. We asked him about it. We heard about the smoking cessation, and then we, discussed the risks and benefits of using an anti-epileptic medication. So I want to leave you with a couple of concluding points. I can say that, at least personally, TDM and sort of knowing how to interpret Clozapine levels has really improved my effectiveness as a clinician when working with patients who have TRS and who have just sort of a long history and complexity. It's helped us to really understand the efficacy, helping Clozapine really be prescribed more safely. You, in your practice, are going to see patients who have levels that are higher or lower than you would expect. And really, it helps to have a framework to think about them, which we've described in this presentation. So think about, a house with a lot of little kids running around and magnifying glasses everywhere. You want to do the detective work, and you want to have a spirit of inquiry around trying to figure out what's going on with the low levels. And finally, developing a management plan for levels that are too high or too low is important. Having a framework is useful because you may have somebody on call that isn't used to managing high or low levels. So one final point is you can even consider drafting a memo for them, sort of some sort of document that kind of goes over what to do with a level that's too high or too low. All right. And with that, we have about 9 minutes for questions.
Thank you so much, Dr. Cotes. This was definitely very informative. There are a couple of questions, and so as we're going through these, if there are additional questions, the question and answer boxes are open, so please jot those down. one of the things I think is always very confusing, Dr. Cotes, is when we think about once nightly clozapine, wouldn't a true trough be right before that next dose? So maybe a little bit of information about why we're targeting 12-hour troughs if we're using clozapine once a day.
Yeah, my understanding is by convention, we use a 12-hour trough for clozapine and for other, sort of. So I think my understanding is by convention, the 12-hour trough is used.
Yes, that's my understanding as well. That's where it is. So usually, we're always going to have that one patient, right, that still is getting clozapine twice a day. Is there a different range that you aim for? Is it different than that once a day, 12-hour trough?
Yeah, so for people with divided dosing, like I have some people who are even on 3 times a day dosing, and I have tried really hard to change that and consolidate that. From both it's difficult to kind of get out of bed with 100 milligrams of clozapine, and then once you get out of bed, then at lunch you get another 100 milligrams of clozapine, and then so despite a lot of efforts, BID and TID dosing still exists, and sometimes, especially for people with orthostatic hypotension, divided dosing, a third in the morning and 2/3 at bedtime, can actually be helpful. So I think that using the patient as their own control is sort of the most important thing here. So I, will get the 12-hour, I'll try to get a 12-hour trough. They take the bedtime dose, hold the AM dose, try to get into the morning as much as we can. It does become more complicated when you're seeing somebody in the afternoon. They get the level, they've already had the AM dose. So it is more challenging that way, but that's sort of what happens in the real world. And we'll just sort of interpret the level based on that patient, how they've been doing over time.
Excellent. And we may have missed this in the presentation, but what is your reasonable monitoring frequency for clozapine levels? So I guess this may be different if you're in titration versus maintenance, but maybe if you could give us some insight into both of those different stages.
Yeah. So for titration, you can kind of pick a level that you would, or pick a dose that you would want to try to look at. Some people would say 100 milligrams, you got to a dose of 100 milligrams, check a level. What I actually am interested in, looking at a possible level rather than a possible dose, especially early in the titration. So I like to get a level, the first one, when I am predicted to see a level of 100 based on some of the normograms. And the reason is that with the immunoassay, the lower limit of detection is 68. So I want to make sure that we are getting a level that is going to come back with something that is a little bit more interpretable. So the sort of that's kind of what I like to do is think about what level would come back at 100 nanograms per mil. I like to get them, so that's actually fairly early in the titration. As far as ongoing, I use clozapine levels frequently. Like a lot of the case presentations we talked about today were just sort of like a spot clozapine level, and it came back high, and sometimes it came back low, and then actually, it resulted in a different clinical decision if I wouldn't have got the level. So I order them pretty frequently. For patients on monthly monitoring, I'll order them pretty frequently. And I often think about, reasons not to use a clozapine level. Certainly for people who are, coming off of clozapine, we don't check levels routinely. And I think that, so I guess that's sort of like the initiation part and then the maintenance part.
I agree. If they're getting stuck for their regular blood cell monitoring, you could just throw on a level if you have the immunoassay, or if you're doing LCMS, know that it's going to be a send out. But I think you've uncovered some situations where perhaps maybe you didn't anticipate the level not being in the area. So getting it more often than not, like you said, I think it only helps. Can't hurt.
The other point to that is if you have people who are pretty much exclusively getting, point of care ANC monitoring, where, they may have access issues to coming in to get venipuncture. I have a lot of colleagues on the ACT team who really prefer, the otherwise Clozapine wouldn't be available to that person. And in those situations, I would probably be a lot more thoughtful about when I got a level and who I got a level for. Just since the point of care testing can really increase access. We don't have that system in my hospital setting, so everybody essentially is getting venipuncture, so it makes it very convenient to get a Clozapine level since people are already getting stuck.
I know we are coming up against the hour, and there are quite a few questions here. Please note we are jotting those questions down if we don't get to everything today. Where we'll come back to those and figure out a way maybe to post the questions as well. But one of the cases you mentioned, considering an anti-epileptic prophylactically, in your clinic, is there a Clozapine level or a dose at which you begin to start considering that process?
Yeah, that's a question, and I think there's been a lot of healthy debate around this issue. I kind of see it like, there's a not inconsequential risk of seizures related to Clozapine at, even lower doses or levels. I think some people like to consider prophylactic AED with a level greater than 600. I usually don't. And if somebody has a level greater than 1,000, I might consider a prophylactic AED. And I think it also just, kind of depends on the person's, sort of overall health status. But I think one of the problems is that, valproate is really one of the better options for prophylactically heading off seizures or treating seizures that can accompany Clozapine. And for me, the problem is around using valproate. I mean, you kind of have a cardiometabolic double whammy, and then also increasing risk of neutropenia, and then also the potential kinetic effects. So it's not a medication that I really like to use unless I really have to, and that's probably one reason that I will wait until levels are higher if we have to.
Well, thank you so much, everyone. We are at the top of the hour, so I want to be cognizant of Dr. Cotez's time, but I want to thank Dr. Cotez, AAPP, and Saladex for having us all here today, and thank you for the great discussion.
Thanks, everybody.